Slides. Today's session is moderated by Dr. Pradeep Reddy sir. He is HOD of Critical Care Department at Medicore Hospital, along with me here at Medicore Hospital, Hyderabad. And today, next few minutes, we are going to discuss oxygen therapy in ICU. Next. Here I would like to mention about one of the event, EuroAsia 2022, which is a 4-day conference, including 2 days of workshop and 2 days of workshop. It will be held in New Delhi. Next, the eminent faculties are there from across the Europe and along with faculty from India. Next, the session which will be there most of the time from morning to evening in last 3 days, and you can register on next this euroasia22.com. So whoever is interested, kindly register yourself for EuroAsia 22, and we'll go with our presentation. I would like to start this presentation with a case scenario. In a normally routine ER or maybe in the ICU, we may have encountered many number of patients. Among them, many of them are COPD patients, hypertensive. Similar way, here the patient is 67-year-old male who is hypertensive and COPD, who is on a regular treatment with antihypertensive and inhalers. And he is an ex-smoker. He came to the ER with complaint of shortness of breath since 4 hours. On arrival to ER, the heart rate is around 110, BPA around 130/90, SpO2 89% on room air, and respirator is around 28. He is afebrile. While auscultating, the wheeze was present bilateral in both sides, but there was no any obvious crepitations. So, what should be the first intervention in ER after recording his vitals? Just form an answer in your mind. Maybe many of you might think, okay, because patient's oxygen level is around 89 and patient is breathless since last 4 hours. The first basic reflex, what we have seen in our staff is they will start oxygen. And let's see how it goes. Next slide.
So, one second, Chandresh. Dr. Rohit is asking what is the ABG of the patient.
ABG, this is a case scenario. ABG will come later on.
Okay.
So let's continue the case and we'll have a little more clarity. So considering the patient's tachypnea, he was started on oxygen by face mask with 6 liters per minute, and the blood samples were collected by the nursing staff in ER. Still the patient is in ER, and at the same time, he became little drowsy and desaturated. And because patient was not responding and there was a doubtful airway protection, he was intubated in ER and later he was shifted to ICU. The ABG, which was taken immediately after intubation, which showed pH of 7.05, PaO2 of 158 mmHg, and PCO2 of 98 mmHg with base excess +2. So what is the reason for desaturation in ER? This question I am just asking you so that you can form the answer on your own, and you can think, suppose such patient comes to you, how you will proceed. So here we'll discuss this case in detail, plus we'll try to address these questions like, was this condition avoidable? What should be ideal approach to treat such kind of patient in ER? So let's see. Here you should understand, next slide. Explanation for this patient desaturation in ER, we should think about COPD patients. Generally, in a normal population, a patient will have 2 types of central drive. One is a high level of CO2, which can trigger the breath, or other low level of oxygen. Because the COPD patients have always higher carbon dioxide level, they have only one trigger for respiration, and that is a low level of oxygen. Once you start providing higher oxygen support to the COPD patient, the respiratory drive will be lost because they are dependent on mainly on low level of oxygen, and they will start doing hypoventilating, which can lead to additional CO2 retention. The additional CO2 can cause more drowsiness, causing apnea and eventually respiratory arrest. So here, next slide, we can see that if you look at the guidelines, and if you think about oxygen therapy, the COPD patients are not entitled to receive more amount of oxygen for longer duration. Yes, if the reason behind the tachypnea is identified here in this patient was tachypnic since last 4 hours. But if you look at the oxygen level, he was having oxygen level of 89%, which is the ideally acceptable limit as per the COPD patients are concerned. So here, if you think about the tachypnea, maybe there can be other reason like bronchospasm, and only the nebulizations with bronchodilator might help. So instead of starting straight away oxygen therapy for such patient who is giving a typical history of COPD, maybe previous hospitalizations, and who are comfortably talking even with 89% of saturation, you should try to maintain the same amount of oxygen level and do not get panic to increase the oxygen level up to 95 or 96%. Otherwise, such patient can land up into trouble. If you discuss about the oxygen therapy, let's define the oxygen. The latest guideline, German guideline S3, they have described nicely oxygen as a drug with a specific biochemical and physiochemical properties, a range of effective doses, and may have side effects also. Just like any other drug in the ICU and in ER, there should be a prescription for oxygen therapy too. But unfortunately, we don't follow that much. If you really think about the patient's possible outcomes, you should always try to identify if you are discussing about the oxygen therapy, or maybe if you are advising somebody for the oxygen, you should ask this 4 questions to yourself. Which patients are really getting benefit from oxygen? So whom to give? At what flow rate it should be given? By which modality or by which instrument you are going to deliver oxygen to this patient? And how long you are going to supply oxygen therapy to these patients? That's why it is very important to know about the oxygen therapy. Next. So being a nursing staff in the ICU, you might hearing these words very often. This terminology is very essential whenever you are reading about the oxygen therapy, whenever you are listening, or maybe if you are discussing about this oxygen therapy. Hypoxia, low level of oxygen in the tissue level. Hypoxemia is the low level of oxygen in arterial blood. Many times people will get confused between these 2 words. So remember, this hypoxemia eventually lead to hypoxia. If you think about the PaO2, it's a partial pressure of oxygen, also known as PaO2. It is a measurement of oxygen pressure in arterial blood. FiO2 is nothing but fraction of inspired oxygen, is the concentration of oxygen in a gas mixture. If I ask you, what is the FiO2 right now you are breathing? So you can easily answer 20.9 or approximately 21%. So we are breathing oxygen at a 21% FiO2. SpO2, it's an oxygen saturation. It is a fraction of oxygen saturated hemoglobin related to total hemoglobin in the blood. And SaO2 is the oxygen saturation as measured by the ABG. The one word which you should be familiar with, it is a peak inspiratory flow. It is a maximum flow achieved by an individual during an inspiration. So here again, it will be in a unit of liter per minute. Next, let's start our discussion with MCQs, and in between, I'm going to ask few basic multiple choice questions. In your chat box, you can answer them, and let's see how are the responses. What is the target SpO2 in COPD patients? Though we have discussed the case, there is a particular number which you are supposed to know. Either it is less than 85%, 88 to 92, 95 to 98, or 100%. Next, if you look at the answer, it's
many of them have answered B.
Most of them answered B, right, sir?
Which is right.
Right. And even the British Thoracic Society has also given the recommendation. Always remember these 2 numbers. If a patient is having a significant history of acute exacerbation in the past, if patient himself is telling the patient is an active or maybe chronic smoker, then your suspicion to the COPD patient should be more. And at that point of time, 88 to 92 should be the number which should be fixed in your mind. Never try to achieve 95 or 98. By doing that, maybe we might give harm to the patient. Next. Now, let's see what are the indications. Oxygen therapy is a treatment of hypoxemia. Never think that any patient who is a breathlessness will require oxygen. No, not at all. Indication of oxygen therapy, there are few accepted conditions. If you see that patient is having a PaO2 in the ABG, which is less than 60 mmHg, or if you see the SaO2 in the ABG, which is less than 90%, you can start oxygen therapy. In an acute care situation in which hypoxemia is suspected, like sudden respiratory distress, such patients will require oxygen therapy. A patient who met with a severe trauma, most of the time they will be obtunded, they might be drowsy. In that condition, maybe it is beneficial to the patient to give oxygen to such patient. Plus, a patient who has recently developed acute MI, and there is also hypoxemia. In such patient, you can start. A patient who is having a low cardiac output with metabolic acidosis, or a patient who is in a severe shock. These patients are the ideal patients we should receive the oxygen therapy. There are few indications which are questionable. Like many setup, we have seen that patients who develop MI, immediately first therapy, MONA, morphine, oxygen, means oxygen will be there. But it is not the scenario in every time. Maybe sometime patient will be completely oriented without any shock or without significant hypoxemia. In that patient, it is a questionable. Any patient who is having a sickle cell pain crisis or a pneumothorax, in this patient also, oxygen therapy might help. We'll discuss about it later. Next. Let's see how to give this oxygen. There is a word called oxygen delivery systems. If you broadly divide them, they can be divided into normobaric and hyperbaric. Hyperbaric oxygen therapy, it is generally nowadays very rarely, and particularly carbon monoxide poisoning, such therapy might help. If you think about normobaric oxygen therapy, which we generally practice, you can further divide it into, depending on the dependency, either low dependency, medium dependency, or high dependency. If it is a low dependency device, it can be further divided in a variable performance and fixed performance. I will explain these 5 words to you so that whenever you touch any oxygen delivery device, you should think about it, whether I am dealing with a low dependency device or whether I am dependency with variable or fixed performance device. Next slide. So low dependency means only supplemental oxygen alone is sufficient to correct the hypoxia. In this scenario, most of the time, patient will be spontaneously breathing. If you think about medium dependency, here there can be a respiratory distress, and because of that, along with the supplemental oxygen, there should be some amount of respiratory assistance which is required. For example, CPAP. A patient on CPAP or BiPAP might be breathing on their own, but they might not have enough strength to breathe, and that's why additional support will be required to relieve respiratory distress. A patient who are having a requirement of high dependence, this device means a supplemental oxygen along with the full respiratory support, like IPPV, invasive positive pressure ventilation. Next. So again, dividing these devices into major flow systems, low flow system and high flow system. The flow rate, which generally goes more than 15 liters per minute, they all come into high flow systems. So here, the nasal cannula, simple mask, reservoir mask, partial rebreathing mask, non-rebreathing mask, all comes under low flow system. Here, because of the Venturi effect, the Venturi mask generally gives higher amount of flow, and this comes as a high flow system. HFNC, blenders, this, I think in this pandemic, our exposure to the HFNC devices might have went up. And if you divide this system into variable and fixed, means it is a FiO2 we are talking about. Right now, if you're talking about the low flow system, it means variable performance. Here the FiO2 will not be fixed. It depends on multiple factors, including the patient effort and patient breathing pattern. But if you think about the high flow device, they can give certain perfect, precise FiO2. Next. Let's start with one by one. Nasal cannula. It consists of 2 soft prongs attached to oxygen supply tubing. Here you can give oxygen flow rate of 1 liter, 2 liter, 3 liter, or 4 liters. And if you think about 2 to 4 liters per minute, here FiO2 which will be delivered, it will be 0.28 to 0.36. And here, simple way of calculation. If you think that we are breathing at 21%, consider we are breathing at 20% of FiO2, each liter will give extra 4%. So if a person is receiving 1 liter, means you should consider FiO2 is 24%. If person is breathing at 2 liters, it means patient is breathing at 28% FiO2. So remember this golden rule, 1 liter is equal to extra 4% of FiO2. And here there will be no increase in FiO2 if you increase the flow more than 6 liters. Here the nasopharynx cavity, it will act as a reservoir, and if the patient breathes through the mouth, this airflow produces a Venturi effect. About this I will talk little later. In the posterior pharynx entering oxygen from the nose, the different devices has been invented, particularly more to give comfort to the patient: curved prongs, flared prongs, curved and flared both, and straight prongs. Many patients they will be using along with the ear guard. Next. So if you look at the nasal cannula advantages and disadvantages, it is ideal for the patient for the long-term oxygen therapy. Many patients on chemotherapy, palliative care, they will be on nasal cannula. It is a very lightweight and comfortable device. Patient can speak, patient can eat and drink. Humidification is not required in such thing because whatever amount of oxygen is going through the nasal cavity, it has to go through the nose and through the nasopharynx, and then it will enter into the trachea. So natural humidification can be expected with a low rate, and definitely the low cost is another additional point. The disadvantage is like it can never provide a high flow. Irritation can happen and it cannot be used in the nasal obstruction patient. FiO2 varies with the respiratory efforts too, and there is a high flow rates are really uncomfortable to the patient. As previously I told, each 1 liter is equal to extra 4% of FiO2 above the 20%. So you can really calculate how much FiO2 will be given if you put the patient at 4 liter for nasal cannula. Next. Let's talk about nasal catheter. Generally, this is more used in a pediatric patient. It goes up to the upper tip of uvula. You can see here. And next, it's a single lumen catheter which is lodged into the anterior nares by the foam collar, and it is inserted just above the uvula. The oxygen flow rate, again here it is 2 to 3 liters, and it can be used to achieve the FiO2 of 35 to 40%. It should not be used when a nasal cannula, nasal mucosal tear is present, because there is a high risk of surgical emphysema, because it is a little bit invasive. The deep insertion can cause the air swallowing and gastric distension. That's why every 8th hourly, it should be repositioned and checked about the position. No advantages over nasal cannula, nasal catheter is concerned. Next. Now another MCQ, which one of these devices provide always the fixed FiO2 to the patient? Is it a nasal cannula, simple face mask, reservoir mask, or a Venturi mask? Let's see what answer we are getting from our audience.
Many of the people have answered D, Venturi mask.
Okay, next slide. Yes, answer is D, because remaining 3 devices, if you look at the nasal cannula, simple face mask, and reservoir mask, they will come with a low flow, and Venturi is a high flow. So here high flow devices can give precise FiO2. All low flow devices gives variable FiO2. If you really want to count it, how it is possible, let's see. Same patient, you provide 2 liters of oxygen through nasal cannula. One patient is breathing a little faster. He's breathing at 40 breaths per minute, and he's having minute ventilation of up to 30 liters per minute. Other patient who is comfortable, who is breathing at 10 breaths per minute, so you can say that minute ventilation is 5 liters. So let's think about how much FiO2 will be given if you give the same amount of oxygen supply through the nasal prong with 2 liters to both these patients. A patient who is tachypneic, who is breathing with higher rates, who is having a higher minute ventilation, they will get low FiO2. It will be getting only 26%. If you look at here, if these patients minute ventilation only 5 liters, 2 liters you are giving through the oxygen nasal prong. Other 3 liters is getting from the air, which contains only 21% oxygen. So total amount is 5 liters. And if you calculate FiO2, it will come as a 53%. So the same patient who is a hypoventilating, or maybe who is a comfortable, which is getting higher FiO2, while the patient who really requires high oxygen therapy, and because his tachypnea is there, if you put them on a low flow device, they are actually getting low FiO2, which might not give much benefit to the patient. Next. Let's talk about simple face mask. You all might know the other words which we use for this simple face mask. Hudson mask. Many of you might not be aware about the other name. MC mask means Mary Catterell mask. This is a transparent mask which is provided with side holes, and the reservoir capacity here you can say around 100 to 200 or maybe 250 ml. The different oxygen flow rates result in a highly variable and unpredictable FiO2. Though this is the most commonly used oxygen delivery device in the ICU, but you should remember here, this gives very highly variable oxygen flow rates and unpredictable FiO2. The rebreathing can also happen with this mask if you give oxygen at less than 2 liters or maybe less than 4 liters per minute. Or if patient is having a low minute ventilation, in that case, the rebreathing of CO2 can happen. The 4 liter per minute oxygen flow rate, it delivers FiO2 about 0.4, providing there is a normal respiratory pattern. And the flow, which are higher than 8 liters, cannot increase FiO2 no matter how much you put. Simple face mask can give up to certain level of FiO2 only. Next. Next. Yeah. Simple face mask. 1 minute. I will go back. Yeah. It has an advantage. Yes, definitely it is less expensive. It can be used in the mouth breather also. The disadvantage, yes, because it is continuously covering your nose and mouth, it is uncomfortable. It requires the tight seal. Do not deliver higher FiO2, as I previously told. FiO2 varies with the breathing efforts and interfere with eating, drinking, and communication. And difficult to keep in position for longer time. Every time you have to adjust the strap. Next. Okay, so suppose if rebreathing can happen with a simple face mask, if flow rate is option less than 2 liter, 6 to 8 liters, 10 to 12, or 50 liter. Let's record the answers from the audience. Yes, sir.
Majority of the people have answered B. Few people have answered C.
So here, next slide, Dhaval, we'll see the explanation. Here, just now I told that rebreathing can happen with a simple face mask if you set the oxygen flow rate at 2 liters or 3 liters. Because if you think that patient is requiring 4 to 8 liters of oxygen therapy, you always use this simple face mask. But if a patient who is a very comfortable, requiring minimal O2 support, better to remove the simple face mask and put them on nasal prong, and you can continue with 2 liters. If you see the explanation, the significant rebreathing can happen if O2 is less than 4 to 5 liters. So always, if you think that your oxyflow is set on 4 to 5 liters, you think about removing the nasal cannula and put the face mask. But if it is only 2 liters or 1 liter, always try to put the nasal prong. Next, partial rebreathing mask. You all might have seen this bag. It is a mask with a reservoir bag of capacity of almost 1 liter. Here, there are few differences. The oxygen flow directly into the reservoir bag, which fills completely during the exhalation. It is designed in such a way that it captures exhale gases from the initial part of the expired air, which comes from the dead space. So which basically contains more CO2. Useful in the situation where supplies are limited. If you're transporting the patient and if you think that oxygen cylinder might be half or maybe it will empty sooner, maybe if patient oxygen requirement is more, you can put this mask so that every time patient rebreathes and maybe the amount of oxygen which can be used, we can save it. It delivers an FiO2 between 0.6 to 0.8, almost up to 80% it can deliver FiO2. We are talking about partial rebreathing mask. a minimum of previous slide. Previous slide. Yeah. 1 minute. No. Next. 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 Yeah. Okay. Hold it. And a minimum of 8 liters per minute should enter the mask to remove all the exhaled CO2 and to refill the oxygen reservoir. So remember this number. Whenever you see somebody with a reservoir bag on their face, always look at the oxygen flow meter and see that patient is getting at least minimum 7 to 8 liters of oxygen. The flow rate must be sufficient to keep the bag almost 1/3 or half inflated at all the times. Suppose if every breath, if patient's reservoir bag is getting empty or it getting collapsed, it means it is the time you have to increase your flow rate. Maybe the patient's peak inspiratory flow is significantly high, which is causing or which is demanding higher flow rate. Next slide. What are the advantages? Inspired gas, here it is not mixing with the room air. If you are thinking about the partial rebreathing mask, patient can breathe room air through the exhalation ports if suddenly by chance if oxygen supply gets interrupted because the side ports are open. Disadvantage, yes, more oxygen flow does not increase the FiO2 here, and it always interferes with the eating and drinking like the simple face mask. So here you should understand the both this opening on the side for the expired gas, it is one way a safety mechanism. Here, because there is no unilateral valve, unidirectional valve, here even if by chance if oxygen supply is disconnected, patient can breathe through these holes. Next, if you think about the non-rebreathing mask, the design is a little bit different. Can you see here 2 valves on the side, one between the mask and between the bag and other on the side. So this one is provided with one-way valves between the mask and the bag and between the exhalation ports. Here FiO2 of almost 95% can be achieved with an oxygen flow rate of 10 to 15 liters per minute. Ideally, this NRM mask should not allow entrainment of the air, but because of the safety concern, one of the 2 exhalation ports generally is not provided with the valve. So still, you will find the valve on the one side. Maybe there won't be any unidirectional valve on the other side. The higher oxygen supply rates are definitely required and desirable in the cases where rebreathing of the CO2 would be detrimental. For example, after the head injury, where you really want somebody's oxygen level should be maintained without having hypercapnia. Next. Non-rebreathing mask also has some advantages, like here, the major advantage is highest possible FiO2 we can give without intubation. So if somebody asks FiO2, if you want to deliver 95 or 100, which mask will be useful? It is a non-rebreathing mask. It is suitable for the spontaneous breathing patients with severe hypoxia. And there are few disadvantages, like definitely expensive, require tight seal, interfere with the eating and drinking, and not suitable for the long-term use. And there can be sometime CO2 buildup if there is an oxygen disconnection. Next. Okay, let's talk about the high flow devices. It starts with the one basic principle. You might have heard about the Bernoulli principle. This principle in the physics, it is basically meant for the fluid flow. Whenever fluid passes through the narrowing, and if the pressure drops, there is a definitely flow increase, or maybe the fluid accelerate here. But if you replicate the same Bernoulli principle into Venturi principle, here there will be extra narrowing. If one fluid is passing through the narrow passage and there should be an entrained other fluid, and because of this thing, the A plus B means the amount of fluid will be here little more. So the similar thing is possible with the gas also. When the gas pass through the narrow passage, it will have an entrainment of the extra room air. So whatever flow you are giving, actually you are getting a higher flow. Maybe if you have kept oxygen flow rate of 15 liters, but at the end patient might be getting almost 45 liters per minute of the flow. So in this way, here you can provide the higher flow and prefixed or precised FiO2. So based on this modification, the Venturi mask and Venturi devices are made. It is not synonymous with the high concentration of oxygen. The plastic body of this Venturi mask with the holes, they are on both the sides, and the proximal end of the mask consists of the Venturi device. So here you can see almost 6 different types of Venturi devices. This we can connect either with the T-piece, either with the Venturi mask. The Venturi devices are color coded. Here you will find the FiO2 also written on the mask. And there is one separate device which we call calibrated adjustable Venturi device, which we can directly connect to the flow meter. There, by setting the changes, we can deliver the desired FiO2. Next. Back. Yeah. So here you can see the design of the Venturi mask. It delivers the fixed concentration of oxygen. The size of the construction determines the final concentration of the oxygen for a given gas flow. The forward flow of the inspired gas increases the lateral pressure, and that's why it results in the entrainment of the gas. The smaller the orifice, the greater the negative pressure, and that's why the more amount of the air will get entrained from the atmosphere, which will result in the lower FiO2. So if you think that the Venturi mask is a very smaller or narrow orifice, means you might be giving a lower FiO2. This FiO2 can be 0.24, 0.28, 0.31, 35, 40, or 60. Next. Let's look at this device. This is an adjustable variable device. Here you can set the flow of 3, 6, 9, 12, or 50 liters. And depending on that, you might giving a different flow rate. So with the same 3-liter flow, patient might be getting 47 liters per minute because of the Venturi effect. If you give 15 liters of the flow, patient might get almost 62 liters of the flow with 40% of FiO2. So this device generally we can keep as a wall mount or maybe the patient bedside. If you don't want to use the color coding system, this can be another alternate. Next. Just now I spoke about the color coding. It comes as almost 5 to 6 colors. Advantage I like, we can control the FiO2 very well. It is a fixed, reliable, and precise FiO2. High flow comes from the air, and that's why we can save the oxygen cost. It can be used for the low FiO2 also, and helps in deciding whether the oxygen requirement is increasing or decreasing. Again, expensive, cannot deliver significantly high FiO2 like non-rebreathing mask. Next. Let's see another one MCQ. Which of these oxygen devices should be used for the COPD patients without significant respiratory distress? Which one will be the best? Partial rebreathing mask, non-rebreathing mask, Venturi mask, or Hudson mask? You can for the first scenario.
Majority of answers are B and C.
B and C. Let's look at the answer. Next. Here answer is a C. Just now I told if a patient requires a prefixed or precise FiO2, the best device is Venturi. But yes, here look at the clinical scenario. COPD patient who is not having respiratory distress, means here again, as we discussed in the case scenario, these patients do not need higher FiO2. So it means even the 21% will be sufficient. Maybe 24 or 28%, very low FiO2 will be sufficient for this COPD patient. Which device among these 4 options can give precise FiO2? That is a Venturi mask. And that's why the answer is Venturi. C. Next. High flow nasal cannula. We all know we have used this device a lot in a pandemic. A patient with severe ARDS, when they are significantly hypoxic, breathing at almost more than 45 rates, after high concentration face mask, most of the time we have switched this kind of patients to the high flow nasal cannula. This delivers actually a heated and humidified oxygen by the special devices. There will be one humidification device also attached to the high flow nasal cannula pipe tubings, and there will be one heater which will be electronic heater. So it can give up to 8 liters per minute in the infants and up to almost 60 liters in adults, not 40, up to 60 liters we can give. In patients with respiratory distress or failure, oxygen by humidified high flow nasal cannula, it may be better tolerated than by the face mask. It also has numerous physiological effects, like if you give the gases with the high flow, the anatomical dead space will be reduced. There will be continuously flow of almost 60 to 50 liters, which can invariably fill the oropharynx and which can give the PEEP effect. The constant fraction of the inspired oxygen can be delivered, and there will be a good humidification because of the heater and humidifier. If you closely look at the device, you will see here the components of this HFNC device: gas blender, from where we can set the FiO2, humidifier, which will be filled with the distilled water, heater, it will be electronic, cathodes will be there, and with that the temperature will be maintained around 32, 33 and 31. Here again you can see numbers: 37 degrees Celsius temperature, 35 liter per minute, and 21 is the FiO2. These kind of numbers you will be see on the display. If you look at the design of the tubings, if you see go through the cut section, the oxygen which comes from the oxygen flow meter, it will always run through the central part, and both the side there will be separate lumen which will be containing the warm water. So by this way, this will keep the air completely humidified. Next, if you see about the different modality which can give the oxygen, definitely next is a non-invasive ventilator and invasive mechanical ventilation. Here always it is possible to give the desired FiO2. In non-invasive ventilation, the tight seal is very mandatory. A patient with significant respiratory distress, they may require NIV or either intubation also. Always try to reduce the FiO2 gradually once patient gets intubated, and you always target the optimal SpO2 level. Never continue the higher FiO2 for longer duration if the saturation is very well maintained. Apart from whatever devices we have discussed till now, there are few devices which we use in ICU. Very rarely ambu bag, because all the time patient will have a bench circuit at the bedside. Bench circuit and ambu bag, these two are also sometimes very important device to give the oxygen therapy, most of the time during the transport or in an emergency scenario just before the intubation. So you should be very well versed with these devices. If you have observed, whenever you start using this bench circuit, better to check always the patency of the inner tube. Sometime by mistake, if the tube gets dislodged, maybe you might be giving the patient proper oxygenation, but you will find the hypoxia. Why? Because of the malfunction of the bench circuit. So the simple test which you can run before using the bench circuit is close the valve completely and occlude the main connector point, a T connector or L connector, whatever is there. So by doing that, if you put the oxygen flow liter of up to 50 liters, immediately your bag will completely get inflated. Once it is gradually, continuously inflating, means there is no leak. So this is the simple way to check the patency of the inner tube, or maybe if it is a malfunction, maybe you should not use it. Next, let's see another one MCQ. Which of the following device can give up to 100% FiO2? Is it nasal cannula, face mask, Venturi mask, or non-rebreathing mask? Let's record few answers.
Majority of them have answered C, and few of them have given answer D.
Previously, I told Venturi mask can give the desired FiO2, but never higher FiO2. So in this patient, the answer is D. Why? Because non-rebreathing mask is the only oxygen delivery mask, non-invasive, which can give up to 95% to 100% of FiO2. So always try to remember these four things. These are the only four devices which you are generally routinely using in your ICU practices. So it is definitely you should be aware about the maximum flow rate, what you can give or what you should give, and which FiO2 you can get. So as previously I told, nasal cannula never cross up more than 6. 6 is also a little bit on higher side. If I think my patient is requiring almost 6 liter, I will better use simple face mask rather than using nasal cannula. If you are using partial rebreathing mask, consider it can never achieve 100% FiO2. But yes, non-rebreathing mask can achieve the 100% FiO2. Only disadvantage is suddenly if oxygen supply gets disconnected because of the unidirectional valve, a patient can have a CO2 retention. So be always more careful while you are using non-rebreathing mask. Always check for the disconnection and take care of the patient. Next, O2 therapy for few non-hypoxic condition is indicated in the carbon monoxide poisoning, where the carbon monoxide has a combined with a hemoglobin to form the carboxyhemoglobin. In these patients, you can give continuously higher FiO2, and to resolve the pneumothorax in those who do not require a chest drain, we can use oxygen therapy. How it works? By over-oxygenating the patient, it changes the pressure gradient in the pulmonary capillaries, which slowly draws air out of the pleural cavity. But again, this is not a standard recommendation to treat the pneumothorax. Next. So what are the signs and symptoms if you give the patient oxygen for a higher duration, and by chance, if patient gets oxygen toxicity? It affects the human body in different ways depending on the type of exposure. Suppose if it is a short exposure and you are giving with a higher than atmospheric pressure, it can lead to a central nervous system toxicity. And what are the symptoms of central nervous toxicity? Maybe a patient can have seizure, confusion, drowsiness. And if you have a patient who received continuously long exposure at a normal atmospheric pressure, then this kind of patient can have ocular or pulmonary toxicity. Maybe a visual field loss, nearsightedness, or maybe cataract formation can happen in a patient who use the low oxygen support for a longer duration at a normal atmospheric pressure. A patient can have a tracheobronchiolitis also, or maybe patient can go into acute respiratory distress syndrome as well. Next. Another one question: in which of the following clinical condition oxygen should be given with 100% FiO2 for longer duration? Is it an acute exacerbation of COPD, acute ischemic stroke, acute myocardial ischemia, or carbon monoxide poisoning?
Yeah, majority of them have answered D, carbon monoxide poisoning.
Carbon monoxide poisoning. Because 100% FiO2, that too for very long duration, definitely it is not the ideal condition for the COPD patient. You should never do that. In a patient who has recently developed stroke and myocardial ischemia, if there is a hypoxia, if their saturation level is less than 96%, maybe it is advisable that patient should receive the oxygen therapy. But still, 100% FiO2 for longer duration, there is no role in these two acute condition. In a carbon monoxide level, yes, it is advisable. Next. So this table I have taken from recent guideline, which is published in the German literature, German S3 guideline, which clearly tells about the few clinical scenario where you have to target SpO2 of which limit. Let's see one by one. In a patient, ICU patient who are on mechanical ventilation, generally our SpO2 target should be 90 to 94%. Even if patient is having a 95% SpO2 level, who is already intubated patient, nothing much to worry about if PaO2 is within the range of 60 to 80 mmHg. So don't only look at the SpO2, always try to check PaO2 level in the ABG as well. If there is an acute exacerbation of COPD, as I told clearly, 88 to 92 should be the limit. In a patient who is having an MI, if it is a STEMI or non-STEMI, if SpO2 is less than 90%, definitely start the O2 therapy. If patient is having a cardiogenic shock, their perfusion will be less. The oxygen level should be well maintained between 94 to 98 range. The post-resuscitation means after the CPR, if a patient is completely unconscious, not oriented, not maintaining the saturation more than 94, then definitely you have to start the O2 therapy. Stroke patient, if saturation is more than 94%, they do not need oxygen therapy. Yes, as I told previously, carbon monoxide poisoning patients, they will definitely require the oxygen therapy until the carboxyhemoglobin level reaches to less than 3%. Next. So I have just followed one simple algorithm. If a patient's pulse oximetry, it shows low level, what he will do. If oxygen level is between 80 to 92%, and if a patient is having a COPD history or a smoker who is having a high risk of hypercapnia, our target PCO2 should be less than 45, and you should continue the conventional oxygen therapy with the targeting of SpO2 between 88 to 92. If a patient is not having any risk of hypercapnia, still you can go ahead a little bit more further with the oxygen. SpO2 level 92 to 96% should be your target. And still, after giving of 6 liters of oxygen, still if patient is hypoxic and SpO2 level is 92%, you can consider HFNC after looking at the ABG. Next. So these are the take-home messages. Initial oxygen therapy, initiate the oxygen therapy only if it is indicated. Always prescribe flow rate, duration, and oxygen therapy device. Always reduce the FiO2 gradually once the patient is on mechanical ventilation, and provide always humidified oxygen to the tracheostomized patient. Here I would like to more pressurize on humidification, because a patient who is in the ICU, maybe they will require oxygen therapy for a longer duration. If your patient is on the ventilator support, and if you find that patient is having a copious secretions and all, or maybe the crusty secretions are there, it is always advisable to start the humidifier as soon as possible, along with the invasive ventilation, along with the circuits. If a patient is tracheostomized, maybe they will be breathing through the room air also, sometime on thermovent. But always remember, a patient who is a tracheostomized, they will always require some or other modality of humidification. So in that way, the HME filter, which is a corrugated papers, which can maintain the humidification, it should be there on the tracheostomy tube. So always remember, tracheostomized patients' humidification should be well maintained, because their air is bypassing the nose and oropharynx. So there is no natural humidification is happening. And many of the times you might have seen that patient who is requiring 1 or 2 liters of oxygen support, they will also get some humidification from the wall mount. It is not ideally required, because if a patient oxygen requirement is only 1 or 2 liters, it means they are having the own natural humidification from the nasal cavity. Yes, if you are using this with a very higher flow, like 18 liters, 15 liters, 20 liters, it means a patient can have a dryness of nasal mucosa, they can have the bleeding, the secretions might get crusty, and patient can have a airway collapse, and bronchial secretions can be blocked into the one of the bronchus. Patient can require bronchoscopy as well. So humidification is a very important aspect to take care. Always think about possible adverse effect of the prolonged oxygen therapy when patient stays in the ICU for longer duration, and consider oxygen as a drug which can cause many complications if it is not given in a proper way. Thank you. Next. Any questions?
Thank you, Dr. Chandresh. Thank you for your crisp and informative discussion on oxygen therapy. Now I'd like to open for discussion. So not many questions. I would like to ask a few questions here. First thing is regarding COPD patients. If a COPD patient is there and he is requiring oxygen support, what is the device which interface which you are going to advise? Between nasal prongs, a minimal oxygen support, say 5 to 6 liters. So between nasal prongs, face mask, and Venturi mask, what is the interface which you are going to advise?
This question to the audience, sir.
Yeah, audience as well as you, anyone can answer.
Yeah, let's see the responses from the audience.
So if at all, can you please repeat the question? Okay. A patient of COPD requiring oxygen support, what is the interface which you are going to advise? If he is requiring, say, 2 liters, what is the interface? If he is requiring 6 liters, what is the interface? I said COPD patient. Somebody is saying ARDS, PF ratio, and oxygen therapy. Please throw some light. Okay, we'll discuss that. Nasal prongs. A few people have advised nasal prongs. So if you are doing anything more than, say, 4 liters or at least 2 liters, more than 2 liters, up to 2 liters, you can use nasal prongs. But if it is using more than 4 to 6 liters, it is always advisable to have a Venturi mask, because if you are using the normal Hudson mask, what happens is CO2 retention will increase because of rebreathing. Okay, that's one aspect. Secondly, in patients who are naturally breathing and not requiring any interface like ET tube or TT tube, would you use humidification with distilled water or normal saline, whatever it is? Anyone can answer. So someone is saying chances of infection are more, better not to use saline. So they say not to use anything, no humidification. What is your take on this, Chandresh?
Yes, sir.
What is your take on this? If
Just saying that,
not to use anything. It depends upon the flow which we are giving. Say, suppose up to 6 liters of flow, if oxygen is required, at that point of time, yes, you may not use anything which is not required. But if you are using more flows, usually what happens is the more flows, we restrict it for shorter duration of time. Suppose you are requiring 15 liters of flow, that means you're going to decide whether to put him on ventilator or something like that. Then at that point of time, for shorter duration of time, okay. If you are using it for longer duration of time, on Venturi or anything, yes, humidification is required. If more than 6 liters of oxygen is being given, or 6 to 8 liters of oxygen is being given, some amount of humidification apart from the natural humidification from the nasopharynx is required. Okay. Any more questions?
Somebody has written minimum FiO2 we can keep patient on if he is on ventilator. So here there is no clear-cut demarcation number, but if you are really winning the patient, here ventilating such patient with the lowest possible FiO2, so you can keep up to 30%. If FiO2 which we can keep minimum on ventilator, it can be a 30 or 40. But if you are thinking even lower number, it means patient at that point can be extubatable and he might not require a ventilator support at all. So answer is maybe 30 or 40% FiO2, still you can go ahead.
So what is absorption atelectasis? My question. Anybody can answer. Humidifiers are filled with distilled water or empty. That we have already discussed. If flows are less than 6 liters per minute, you need not have any kind of humidification. Natural humidification through your nasopharynx will suffice. But if it is more than 10 liters, usually what happens is if you are using high flow, there is more than 10 liters or 15 liters, at that point of time, you will decide when whether you put him on ventilator or not. If you are using a NIV also, you use HME over there. If you are not using an NIV, you are putting on ventilator, you definitely use HME over there. The shorter period of time where half an hour, 1 hour, that's okay. But if you are using for prolonged period of time at more flows, more than 10 liters per minute, at that point of time, your nasopharynx will get dried up. So it's better to use a humidifier.
Here, Dr. Krunal has asked one question, sir. How COPD patient can have only one trigger if they have high CO2? As I told, a normal person can have a two trigger. If somebody's oxygen level can go up high, that is also a respiratory trigger. If oxygen level is very low, in a patient who is a COPD, they are a chronic CO2 retainer. So because of continuously higher oxygen level, in that case, the respiratory drive is only dependent on the lower amount of oxygen. The moment you try to hyper oxygenate them, extra amount of oxygen, the one drive which is intact in them, it will also get lost. So the COPD patient, because of the higher CO2 level, they are only dependent on lower oxygen level as a respiratory drive.
Okay. What is the name of the toxicity? That is what toxicity is talking about? I don't know. Maybe he's talking about the toxicity or adverse effects of oxygen. So if you point out oxygen toxicity or adverse effects of oxygen, see, oxygen toxicity will happen if you use smaller. There is no FiO2 where oxygen toxicity will not happen. Say, suppose you are using 30, it may be safe to have 30 or 40 FiO2 for prolonged period of time. If you are using 100% oxygen, the toxicity will happen sooner. That the relationship is like this. If you are using higher FiO2, the shorter duration of oxygen therapy will cause toxicity. If you are using lower FiO2, you can give oxygen therapy for a prolonged period of time, so that if toxicity has to happen, it will be much later. Absorption athletics is what I was talking about. That's one more side effect. And retina, if you're using in premature infants, then you have retinitis, retinopathy of prematurity. That is one more toxicity. And CNS toxicity, you can have seizures. Actually, Chandresh has clearly mentioned the entire organ-wise what are the toxicities you can expect. And especially if you are using in patients with pneumonia, ARDS, you can have pulmonary fibrosis. If you are using higher FiO2 for longer period of time, where you will be forced to use for the FiO2, higher FiO2 for longer period of time, as long as the patient is not improving oxygenation. So there they can develop pulmonary fibrosis. These are some of the toxicities or adverse effects of oxygen.
I think the name something like CNS toxicity, CNS symptoms, something like BERT toxicity or BERT, BERT. It was like maybe toxicity can be BERT effect. Yes, it's a burnt. I think BERT.
Yeah, BERT effect.
Okay. Okay.
And regarding sterilization, which is important, how do you, suppose if a patient has come and you are using face mask on him, how do you keep the face mask clean? How do you sterilize those face mask or your interfaces? How do you, suppose the patient gets onto ventilator and if you are forced to keep that face mask in your cupboard, and how frequently you have to use, or you going to use the same face mask for other patients also? So speaking, for every patient you have to use one device, and all these plastics, any of the plastic, yes, you can use one patient, one device, one interface. And if you are have to keep it off for some time, you should not place it on the bed, you should not place it on the floor, let it hang in the air, and cleaning it bacilloid is sufficient before just reintroducing it to the patient. Okay. Any more questions? If there are no questions, I think we have answered everything. Someone is asking about difference between Bernoulli effect and Venturi effect.
Actually, Bernoulli is the principle and Venturi is the effect. So the thing is, initially, when Bernoulli principle was applied to the liquid, they have just told about the pressure. There is a drop in the pressure which increases the speed of the liquid. And the same thing, if you apply to the gases, and here the extra thing has been added, it is a narrowing. Once the lumen gets narrow, the lumen, the pressure will drop. Once the pressure will drop, the extra entrainment of another air will come. So that is called Venturi effect. So little bit difference between Bernoulli and Venturi. Here, maybe you can see the liquid and gases. The Bernoulli effect mainly initially applied on the liquids, while Venturi effect most of the time it's used in the gases.
Someone is asking about ARDS and PF ratio and oxygen therapy. In ARDS, the lowest possible oxygen should be used to target a saturation of 92 or 93, around 94. That is what 92 is one, which is being at 88 to 92. So you need not target 100% saturation. You can target 92% saturation, and the lowest possible FiO2 to maintain that, along with your PEEP and other adjustments, it should be used. All right, I think we have answered every question. The difference between Bernoulli and yeah.
Thank you, sir.
If there are no more questions, thank you so much for attending, and thank you ICM for giving us this opportunity.
Thank you everyone.